Hi, my name is Dr. Donald Jurovich. I'm a professor of geriatrics at the University of North Dakota School of Medicine and Health Sciences. I would like to present part of our age-friendly healthcare system series with the topic of what matters, and this is part 3 of a 3-part series to discuss one of the elements of the geriatric 4Ms. So the goals are for this presentation are to look at a health systems approach to address gaps in the 4M assessment and management, report the impact of what matters on health system costs, and then strengthen patient-centered care by addressing some of the cultural aspects of looking at what matters. So here's a case study for you. The Clinical Quality Improvement Director provides a report on documentation of what matters in the electronic medical record. You are considered physician B, as you can see here in the orange, and the threshold for the CMS metric is to have 90% or better documentation of advanced care plans. And so basically you can see here that there's some variation between providers, one doing not quite as well and others doing maybe a little bit better, and you're right in the middle. So the next best step to improve quality metrics on what matters would be, and these are your choices. So you put a sticky note on your workstation to remind you to do what matters. You create a personal what matters smart phrase in the EMR so that with each patient encounter you now are able to fully assess what matters. Option C is to join colleagues in a plan, do, study, act cycle of change. And then lastly, you instruct your intake nurse to ask each patient what matters each day that you're doing your clinic. So please pick your best option here. And I'll take us to the answer here. So the most correct answer would be to set up a plan, do, study, act cycle of change. If you see the other 3 choices, they're all individualized towards yourself as an individual physician, and that's not really going to impact systems change. I mean, you may be one physician amongst hundreds, and so the impact that you're going to have on age-friendly healthcare is going to be minuscule compared to the rollout amongst all providers. So that's why option C is the best choice. So when we address health systems change, there is some documentation through the Institute for Healthcare Improvement. You can actually go to ihi.org and see some of the resources that they have for health systems change related to what matters. So some of the techniques that can be used in redesigning healthcare for what matters is to have a pre-appointment prep with the patient. It could be a pre-visit questionnaire that could be done in the waiting room, or it could be mailed out to the house, or they can be invited by my chart or the electronic medical record portal. Another way to try to identify what matters to the older adult is to provide them with a pre-appointment card deck, and they have different comments on there, and they select the ones that are most important to them, and then you align that with their healthcare plan. I mentioned in a previous presentation that you could use what's called target practice, where sometimes you just have these little stickies or magnetic labels that you put onto a target, where the center part is the most important fact that goal that the patient has, with lesser importance put on the outer rings. Some institutions, and I've listed a reference here, have used a patient passport. This is not a immunization passport or a COVID passport. This is more of a what matters passport, and it again walks you through the different questions that help with the documentation in the electronic medical record. Another novel intervention would be to develop group visits These would be moderated with discussions amongst the patients and either a provider or a facilitator who could be a healthcare worker to talk about patients' goals, preferences. You can even do self-management skills and so forth with these types of group visits. We've actually implemented a caregiver training group visit through our clinic at Sanford Fargo and have had some early success, both in caregiver engagement and benefits that they accrue as a result of their participation. You can also harness community health workers. So if the individuals happens to have a parish nurse, that they can go to, the training the faith community nurses could be an important adjunct or conduit to establishing what matters. There's EMR templates, and you could design your own. Some thoughts being is that if you want to identify somewhat of an epidemiologic survey of how people feel about their health and well-being, you could do what's called the self-filled form, the SF-36. There's also a shortened form of that. And there are other forms that you can use to establish values and healthcare goals. So basically, the SF-36 has many of these and could even be used for quality improvement in research because it's a validated tool. And again, I'm not, I want to emphasize that I'm not advocating for the SF-36 to be used on a routine clinical basis as a every encounter what matters assessment tool. It's rather a more of a 30,000 foot view of patient care preferences and well-being. So it's important to improve provider and staff training, certainly with motivational interviewing, how to work with shared decision making. There's a app called Jerry Talk. It's a model for communication skills training that's focused on the older adult. In considering cultural diversity and what matters, it's important to establish some very basics. You know, how does the older adult want to be addressed? Do they want to be addressed by their last name, by their first name? Find out if there are language issues, what their preference is for speaking. It's generally good to get an interpreter, even if a family member wants to volunteer as the interpreter. Sometimes that just doesn't allow the patient enough latitude to express what their concerns are. And that may be particularly true of post-traumatic stress syndrome. Up to 75% of new Americans and refugees have some form of post-traumatic stress syndrome. So that's important to evaluate. And again, having the family member in there may not allow them to maximally or optimally express their concerns about their previous stressors in their life that have lingering consequences. It's also important to establish what alternative therapies might occur. I remember dealing with a group of patients, Hmong patients, who had a lot of interest in scents and herbs and candles, you know, as part of the vapors, you know, for improving health. So it's important to understand those alternative therapies and respect them, as long as they're not toxic. And then to also understand the role of the family in medical decision making. Always be careful of the wayward family member who comes in from, who knows, abroad or from another state, who wants to take over mom or dad's care, but have had no role in the day-to-day caregiving activities. And so sometimes those could be a little bit of a head-butting situation. So I think it's important to look at the reimbursement. So there is a business plan for asking what matters, and these all can be embedded into typically in the annual wellness exam, but it also can be part of an advanced care planning, and so that's why we have consultations that we can use for an advanced care planning nurse, and so forth. So you can see all the different coding strategies that can be used to integrate what matters into the care plan for the patient. So with all of that, I'd like to summarize by saying that what matters is a continuous conversation, just not establishing it once and then letting it go. It has to be applied at each visit and ask individuals, particularly whether there's major life events or change in health status, as to whether there's been any changes or outlooks, towards their healthcare goals. I mean, commonly you might cite the transition with chronic kidney disease into end-stage renal disease and the prospects of dialysis, and what does that mean to the patient. So that would be a most explicit example of sentinel changes that need to address what matters. The other part is that what matters has to be coordinated amongst team members. So each team member on the healthcare team, if you're in a patient-centered medical home, for example, each has a role in establishing what matters. So, for example, if there's a pharmacist involved, they may ask if all those 12 medications, how are they doing for you? Is it a burden for you to take that many medications? Oh, and by the way, some of those side effects that are occurring, maybe from the medications, maybe you're on too many medicines, and so that might be an opportunity to not only ask what matters to the patient, they have too high of a pill burden, then that lends itself to the next geriatric 4M of medications and deprescribing. So you can see, in summary, as to how the different geriatric 4Ms interlace with each other. We want to pursue what matters, always being mindful of the patient's cognitive levels, their health status, what their lifespan, remaining life expectancy is, and what they view as their own individual identity. We need organizational change to impact what matters, and that involves setting expectations for older adults, maybe having them do some preclinical homework, or post-clinical homework, also training staff and providers on the different tools for assessing what matters, such as the Stanford letter to the doctor. And then it's important to understand what the clinical workflows are. I kind of suggested that there might be some opportunities in the original case report where the physician opted to have the intake nurse do the What Matters survey. I mean, that might be one thing. And then, of course, the intake nurse may say, well, you're having me do gate speed, so I don't really have, the workflow or the time to be able to do that. So then you have to come up with another solution. But no one size fits all. It's important for the teams to get together and figure out how the distribution of assessments for what matters and the frequency with which it occurs and the duration with which it occurs. And again, the annual wellness exam is really the foundation for establishing what matters. And so perhaps just even asking patients in your clinic when you do what matters, ask them, have they had their annual wellness exam? And if not, then schedule that. So just as a reminder, we want to apply the geriatric 4Ms with each clinical encounter. And by doing so, there will be increased benefits in terms of quality of life for the patient and also efficacy of your healthcare plan for the older adult. So I want to thank you for your attention. This is the last presentation for the What Matters series, which is a 3-part series. And I look forward to engaging in conversation about the age-friendly healthcare system and reviewing the other 3 elements to age-friendly healthcare, namely mobility, medication, and mentation. Thank you.